So let's talk about primary hyperparathyroidism. So last time I covered kind of the basics of what parathyroids are, but this is now getting into the meat of it and what most people are thinking about. All right, so primary hyperparathyroidism, this is the big one, the most common disease that I deal with, one of the most common diseases of the parathyroids. And so let's jump right in. What is primary hyperparathyroidism? Well, for most people, it is going to be a disease of many symptoms. So when you think about primary hyperparathyroidism, a lot of times what people think of are a lot of non-specific symptoms that they have. So for example, fatigue is the biggest one, but you can also get abdominal pain, constipation, bone pain, insomnia, depression, increased urination, and increased thirst. So this is a disease that causes a lot of different symptoms that are not obviously connected. So you might not really see the connection between having constipation and having bone pain and having fatigue, but they're all common symptoms with primary hyperparathyroidism. So it's a disease of many symptoms. They're often not at all related to what you might think of. So as I said, the parathyroid glands are these tiny glands in the neck. There's usually no symptoms related to the neck, really, in primary hyperparathyroidism. They're mostly throughout the body because the main issue is with calcium, which is happening throughout the body. So just to give you a list of symptoms, the most common ones are in bold. So fatigue, a general sense of not feeling well or not feeling like yourself. Insomnia, specifically waking up a lot. So waking up after 3 or 4 hours of sleep and not being able to get back to sleep. That's very common. Brain fog, or having difficulty concentrating, feeling like you're losing your memory, even thinking that you may be getting dementia. Those kind of things all come under brain fog, and they're very, very common. So the ones in bold, a lot of people get. More than half of people with primary hyperparathyroidism will experience these. But you can also get all of those other symptoms listed there. So increased urination, increased thirst, headaches, bone pain. Bone pain can be anywhere. It is most often in the distal extremities. So think hands, feet, ankles, shins, wrists. But you can get bone pain really anywhere. Heartburn or reflux, palpitations, constipation, all of these things are ways that you can start to feel primary hyperparathyroidism. Note that a lot of them are nonspecific, especially the most common ones. The most common ones are very nonspecific. So if somebody comes to me and says, I'm really tired, I don't immediately leap to parathyroid disease because there's about 1 million different things that it could be if they're tired. But primary hyperparathyroidism is one of them. And if you see something like a high calcium and you have these symptoms, there's a very good chance that your high calcium level is the cause of these symptoms, even if your doctors don't realize it. Okay, now if you let primary hyperparathyroidism go untreated, not only does it cause all those symptoms and make you feel bad, but it also has an effect on the rest of your body that can manifest in a lot of different diseases. So high blood pressure, because calcium increases arterial stiffness. And the stiffer your arteries are, the harder your heart has to work. So it causes high blood pressure. Because parathyroid hormone is taking calcium out of the bones, you get osteopenia or osteoporosis. You can get fractures as a result of that. Because your kidneys are having to process a lot of calcium, you can get kidney stones. And you can actually get chronic kidney disease and even kidney failure even apart from the kidney stones, even if you're not getting kidney stones. GERD, or which is reflux, that you can actually see the damage in the esophagus. Atrial fibrillations and arrhythmias, high calcium levels, even if the calcium's not that high, you can get these cardiac arrhythmias like atrial fibrillation. And insulin resistance, this is one we're learning about more, but you can start to develop diabetes from this, or have increased insulin resistance from parathyroid disease, from primary hyperparathyroidism. So lots of different ways that this disease can manifest, not just making you feel bad, but also causing high blood pressure, causing fractures, causing kidney stones. It can really do a lot. And we know that it does this over time. So sometimes people will present and they don't have any symptoms. They feel pretty good. That's great. We know that over time, the natural history of the disease shows that most people will develop symptoms at some point or complications of the disease. So maybe you're not tired, but you're starting to show osteoporosis, or your kidney function is starting to decline. It's not in the panic range, but your GFR is starting to drop and your doctors are noticing it. That could definitely be from this, and it's something that happens after you've had primary hyperparathyroidism for years. Not always right away. Okay, so what is the underlying cause of all this? You feel bad, but what is actually doing that? Well, primary hyperparathyroidism is a problem of one or more overactive parathyroid glands. It's usually a benign tumor called an adenoma. So parathyroid adenoma is the most common cause of primary hyperparathyroidism. And remember, these are benign. We're not talking about cancer. Parathyroid cancer is exceedingly rare. So we're talking about benign tumors that cause these issues. Okay. Now, last time I mentioned the parathyroid glands. So this is a very inaccurate portrayal, but I will use it anyway. So here's the thyroid, it's kind of the butterfly shaped thing. The little yellow-brown things are, what we're calling normal parathyroid glands. And normal parathyroid glands are tiny. They're usually about the size of a grain of rice or a couple of grains of rice stuck together. They're nice and soft and floppy. But this big one down here, the big red thing, that's representing a parathyroid tumor, because when you get parathyroid adenomas, these benign tumors, they tend to get big, red, firm, hard, and rounded, and they're usually a lot bigger than the other parathyroid glands. So this is the most common cause of primary hyperparathyroidism, is an adenoma of one parathyroid gland. Sometimes we see two adenomas. Sometimes all four glands are actually enlarged and overactive. That can also be a cause of primary hyperparathyroidism, but it's at least one gland. At least one gland is overactive and inappropriate. The diagnosis of primary hyperparathyroidism is based on labs. Nothing else. It is really based on labs. Now, as I said, the symptoms, they're very common, but that's not what we use to diagnose the disease. Because most of those symptoms are so nonspecific, we have to use labs. So here are the labs. It's actually fairly simple. High calcium levels and inappropriate PTH levels, that's usually all you need. That's why those are in bold. A low vitamin D kind of helps. That supports the diagnosis as well, but a lot of times it's not necessary for that. Just a high calcium and an inappropriate PTH, in most cases, can diagnose primary hyperparathyroidism. And I know some of you out there have questions about normocalcemic, and I will get to that, but I might get to that on a future month, because that is its own topic, and it's actually pretty difficult. So normocalcemic primary hyperparathyroidism is much rarer than most people may think, because most of the time when somebody comes to me with normocalcemic primary hyperparathyroidism, it's not actually that. The confusion, I think, comes from what is actually considered a normal calcium. So if you have a doctor that's calling your calcium of 10.5 normal and diagnosing normocalcemic primary hyperparathyroidism, that's incorrect, because that calcium level is not normal. You actually have classic primary hyperparathyroidism. And then there's other cases I get of normocalcemic hyperparathyroidism, which are actually secondary hyperparathyroidism. So I will get to normocalcemic. It does exist. It is a little bit harder to diagnose. You need a little more information. You can't really diagnose it based on one set of labs. So we'll get to normocalcemic, I promise, probably several times we'll get to it, because I know it comes up a lot. But most of the time, most patients can be diagnosed with a high calcium and inappropriate PTH level, full stop. A low vitamin D level can support it. Some other labs can support it, but really what you want to see are these labs. Okay. What about scans? The confusion here comes from the fact that if I tell you that you have a tumor somewhere, a benign tumor somewhere, most people are thinking that there's going to be some sort of growth that you're going to see or feel. So if I have a tumor growing on my arm, I can probably feel it, or I can see it on a scan. That's how we diagnose tumors in general. Endocrine tumors are different. Endocrine tumors tend to be very small, and they may not show up on scans. Parathyroid tumors in particular just do not show up on a lot of scans because they're tiny. So if a parathyroid gland is about the size of a grain of rice, the tumor may be the size of a pea or a raisin, and it tends to blend in with things around it. So those are the problems there. We're talking about something that's pretty small, and we're talking about something that can look very much like either a lymph node or a thyroid nodule on imaging. So we have lots of imaging modalities that we can use. None of them are perfect, none of them are great, and they cannot be used for a diagnosis. They can't be used to say you have primary hyperparathyroidism, because they're just not reliable enough. We have to use the labs for the diagnosis, and then scans exist. They can be helpful. They can be helpful especially if you're already planning surgery, and I will get to why they can be helpful in that case, but just know they're not used for diagnosis. We are not using a scan to confirm that you have this. I can know that you have a parathyroid tumor based on your labs. In most cases, there are outliers, and I deal with a lot of cases that are kind of gray zones, and I'll talk about those because they're very interesting. But for most people, they're not in a gray zone. It's pretty clear, and I don't need a scan. I don't need anything else. I know you've got this. I know you've got a tumor based on your labs. And that's all I need. Okay, now there's some challenges in the diagnosis that come up a lot, especially for doctors too, and for patients who are dealing with their doctors and trying to get a diagnosis. I just want to talk about those for a minute. One of the big ones, and I mentioned this briefly earlier, one of the big ones is that the lab may not flag your calcium as high even when it is. Labs have a certain range for everything, right? When you get the lab result, usually you'll see your result, and then over to the side, you'll see the normal range, what they're considering a normal range, okay? With calcium, the range is way too large. So it'll often be from 8.8 to 10.4. That is too large. An 8.8 is too low for everyone. A 10.4 may be normal if you're 25 years old, but it's not normal when you're over 40. And the lab is not accounting for that. They may adjust for pediatric labs, meaning if you have a child, they may adjust their levels because children have different ranges for a lot of levels. So they may do that, but they're not going to adjust based on adulthood. And so once you're an adult, they give the same range. It's way too broad. A lot of people will not be flagged as high. Another problem is that the PTH level. So I mentioned that the diagnosis is typically a high calcium and an inappropriate PTH level. That could be a PTH level that is always in a normal range. The problem with interpreting PTH is that you have to interpret it in relationship with the calcium. You can't just check a PTH by itself. If somebody comes to me and says, I have a high PTH level, what does that mean? My answer is, honestly, I can't tell you because I don't know the calcium. If you tell me your calcium and your PTH level, then I can tell you what's going on. If you have a high calcium and you have an inappropriately, quote, normal PTH, then that's primary hyperparathyroidism. But doctors are often very confused by this, and they will not diagnose somebody who has a PTH in a normal range, even if it's inappropriate for the calcium. I'll speak on that more in a minute. And then finally, low vitamin D levels. We have to spend a lot of time talking about vitamin D because it's very popular topic for doctors too, but they will check the vitamin D and they'll often misinterpret it when looking at parathyroid disease. Okay, so just to reiterate, the normal calcium levels by age, you can see in this graph Children and teenagers can have much higher calcium levels, and then over time, the calcium levels tend to trend down as you get into your 20s and 30s. And by the time you're over 40, your calcium levels have settled into this range that in milligrams per deciliter is in the nines, typically in the mid to high nines. And that stays throughout your adulthood. But anything over about 10.0 is not really normal once you're over about age 40. So repeated levels over 10.0 are not normal. They usually indicate a parathyroid problem. But you can see the problem here is that if the lab has a range of 8.8 to 10.4, then there are a lot of people who are going to be high but not flagged as high because they are in that range of 10.2, 10.3, where it's truly high, but it's not getting flagged. This can lead to a delay in diagnosis of many years because oftentimes the calcium level will stay in that range. It doesn't need to go much higher, but you have primary hyperparathyroidism, you have all the symptoms, you're getting complications from it, but it's not getting diagnosed because your calcium level doesn't ever reach what the lab calls high. It's a big problem. All right, for the PTH, now go back to thinking about parathyroids as thermostats for calcium. This analogy is really important when diagnosing primary hyperparathyroidism because you have to understand this relationship. The parathyroid glands, when they're normal, so a normal parathyroid gland is constantly adjusting based on the calcium. So normal parathyroid glands, when the calcium is high, will stop making PTH. They essentially turn off the production of PTH. That's what happens in a normal situation. Okay, what about abnormal situation? So what if there's a parathyroid tumor and the calcium goes high? Well, a parathyroid tumor is not going to respond appropriately. It's going to keep making PTH. That's the problem. That's the underlying issue, is it's just making too much PTH. And it's going to do that even when the calcium goes into the high range. But the PTH level does not need to be in a high range. It'll be inappropriate for the calcium. Any PTH level that is not suppressed, meaning not turned off in that low range, anything that's normal or high is inappropriate for a high calcium. So think of the thermostat. Teach your doctor the thermostat issue if you have to, because this is a big problem in diagnosis. And finally, let's talk about vitamin D briefly. So with primary hyperparathyroidism, vitamin D deficiency is extremely common. Most patients will get a deficiency in the form of vitamin D that we measure, which is vitamin D 25-hydroxy, which is the inactive form of vitamin D. It's the one we check because it tends to be a really good a indicator of your overall vitamin D status. Okay, so we check vitamin D with primary hyperparathyroidism. A low vitamin D is common, and a low vitamin D can never cause high calcium. Low vitamin D does not cause high calcium ever. Doctors forget this part because they remember that a low vitamin D can stimulate the parathyroid glands, and they think maybe it can cause the high calcium. That's not what's happening. So in primary hyperparathyroidism, you're actually causing the low vitamin D. PTH production is causing a low vitamin D. Okay, I won't get too much into the molecular structures, but vitamin D 25-hydroxy is on the left here. That's the inactive form. That's the one we're measuring. That's the one we're checking, right? And most people, it gives a really good assessment of their status, but in people with primary hyperparathyroidism, it's not good. Why? Because the inactive form gets converted to the active form in the kidneys. And that conversion, right, that big arrow of the 25-hydroxy going to the 1,25-dihydroxy, that enzyme that's doing that conversion is directly stimulated by PTH. So if you have excess PTH production, you are stimulating that conversion of the inactive form to the active form. And you're using up your inactive form. So you will get a low vitamin D 25-hydroxy and a high vitamin D 1,25-dihydroxy with primary hyperparathyroidism. So that's why I put deficiency in in quotes because you're sort of deficient. You're deficient in one form, but you are not deficient in vitamin D, the active form. You actually probably have a lot of vitamin D 125 dihydroxy. Okay, so just to remember, low vitamin D is caused by primary hyperparathyroidism. Low vitamin D cannot cause a high calcium. If you have a low vitamin D, it can cause a low calcium. That's like rickets. That's when people don't get enough vitamin D and then their calcium's very low. That's what happens. Never causes a high calcium. Okay, so that's a brief overview of the diagnosis. And now let's talk about the treatment. So what is the treatment? Well, we have two options really. Now, I will preface this by saying that I am a huge proponent of lifestyle medicine. I really believe that if you can avoid medication and surgery with lifestyle dietary modifications, then you should. It is really important to maintain a healthy lifestyle and diet and exercise. But with primary hyperparathyroidism, there's really no modification that you can make that's going to have an effect on the disease. It is one of those things that it's caused by a tumor making too much of a hormone, and the treatment and the cure consists of removing that tumor. There aren't really any other options, well, other than not doing anything, which is the watch and wait option. So first option is having surgery to remove that parathyroid adenoma and allowing your other parathyroid glands to then work properly. Or two, watch and wait. Now, it's not an unreasonable thing to do if you truly feel really good and you have no manifestations of the disease. This is not the case for most patients. Most patients feel their primary hyperparathyroidism. They have fatigue, they have insomnia, they have headaches, they have kidney stones, they have something that is causing a problem in their life and diminishing their quality of life. So for them, watching and waiting really is not the best option. Surgery really is the best option. Watching and waiting is an option for the very few people who really truly have no symptoms, which are few and far between. Also, the other thing about watching and waiting is that we kind of know the natural history of the disease. We know what's going to happen. Typically, you are going to get symptoms. You are going to get complications. You're going to get bone loss. You're going to have kidney damage over time. It's a strain on your arteries, your kidneys. That high calcium is really not good for you. We know that. So even if you don't currently have any manifestations of these issues, it's probably a good idea to get it treated. Now, I'm a surgeon, so obviously I'm biased, but really we do know what happens with the disease. We know what happens over time, and my preference is to treat it when it's diagnosed rather than waiting for these things to happen or waiting for you to have symptoms. This doesn't even come up that much because so many patients, almost all patients, come and they have symptoms already. So it's not really an option. But some patients do want to know what's going to happen if I just watch it and wait. And you may be fine. You may be fine for years, but we do know that problems happen and they happen over time. Okay. Common misconceptions. I just want to cover a few, the most common misconceptions. A lot of these are actually doctors' misconceptions and not patients. But these are the kind of myths that a lot of doctors believe. Okay. Here's the most common one. A lot of doctors still believe that most patients are asymptomatic, meaning they have no symptoms, no problems with the disease. You would not even know they had it, except that you incidentally notice a high calcium level. This is not true. This was published a long time ago, and it gets repeated in the literature despite the fact that it's not true, and despite the fact that there are many studies showing this. Most patients have symptoms. They may be nonspecific, they may be fatigue, it may be brain fog, but they are having symptoms. And not all doctors want to attribute all the symptoms to it, and that's okay. I agree. Your fatigue could be due to a lot of things. Maybe you have obstructive sleep apnea, and that's the issue. But I do know that most patients do come with symptoms, and these symptoms tend to improve after surgery, which suggests that they were related to the primary hyperparathyroidism in the first place. Okay. The next myth that you see a lot is that higher calcium is more severe. So this is one with doctors and with patients. They see the calcium level and it's, quote, just a little bit elevated. It's just above normal. And for a lot of labs, that's okay. There's some labs where your body's not keeping as tight of a range as it is on calcium. And so you can see these sort of mild fluctuations in what's normal, and it doesn't indicate a problem. Maybe it indicates something you just want to watch or recheck, and it probably doesn't mean anything. That's not really the case with calcium. Any calcium level that's persistently out of range indicates a problem in most cases. But it doesn't mean that as you go higher with your calcium that you have more severe disease. Some people have calcium levels that are just barely above normal, and they are miserable. They have kidney stones, they have arrhythmias, they get all these complications from it, but their calcium level is just above normal. In fact, the lab may not even be calling it high. And then I have patients with calcium levels that are way out of range, and they haven't had many issues. They're just starting to feel a little bit tired, but otherwise they feel fine. It is not correlated. The symptoms and the problems you see with the disease are not correlated to how high the calcium goes. Okay, and finally, surgery requires a positive scan. Still, I see this a lot. Remember I said that we make the diagnosis based on labs, not on scans. So you don't need to have a positive scan for me to know that you have this. But a lot of surgeons will want a positive scan before they will operate. And a lot of endocrinologists will then want you to have a positive scan before they'll even send to a surgeon, because they've had patients rejected from the surgeon because they didn't have a positive scan. So it kind of self-perpetuates where these endocrinologists are getting lots of scans in an attempt to get a positive so that they can then send the patient for surgery. But really, you don't need a positive scan. Your surgeon should not need a positive scan. If you've got a negative scan and you can't see a surgeon because of that, then you need to see a different surgeon, because that surgeon's not comfortable with doing this operation. But really, you do not need a positive scan. Okay. The reality, just to reiterate, most patients are symptomatic. They do have symptoms. Calcium level, not related to disease severity. And the scans are not necessary for surgery. I operate on a lot of people with negative scans. Probably more than half of my patients have negative scans, meaning they've had probably multiple scans and none of them show a parathyroid tumor. I can operate, find the glands, figure out where the problem is, and get them cured. Okay, so that is all I have for the slides. Now it's a brief overview of primary hyperparathyroidism, and I will now answer some of the questions related to primary hyperparathyroidism. Now, you should, though, go to YouTube, because now I am getting the YouTube channel going. It's Southwest Parathyroid. Go on there, like some videos, and make sure you subscribe so that I can get that going and help educate more people. Okay, so let me switch back to the camera. Okay. All right, so let's get to some of the questions. Let's see. It's easiest for me to read the ones that are currently up here. Okay, so all right, just let's go back to Marta. Okay, so Marta said one calcium level was high normal, PTH was high normal, vitamin D is low normal, and on these numbers, is this indicative of hyperparathyroidism because of a lack of inverse relationship? Okay, so I have to see actual numbers. when you're saying high normal, that range you're giving, that 2.45 to 2.59, some of those are normal. Anything up to 2.50 is normal. Anything above that, if you are over age 40, that's not normal. So this is what I meant by sort of the high normal thing, or when the normocalcemic issue. If you've got a calcium level that's 2.55, that's different than a calcium of 2.45. So I actually always want to see numbers rather than you kind of telling me, oh, it's on the high end of normal. What was the range that you're referring to as normal? PTH high normal, again, kind of want to see the real numbers. And then the vitamin D low normal. So it's tricky. This inverse relationship thing, okay? It's very hard sometimes for anybody to grasp, because I just told you if your calcium level is high, your parathyroid glands should respond to, and an appropriate response is for the PTH to be low, because the parathyroid glands should stop making more hormone, okay? But when your calcium level is in the normal range, you are not necessarily going to see this perfect inverse relationship while it stays in the normal range. So one day you might have a calcium level that is 9.8 and a PTH of 45. And then the next day you have a calcium level of 9.6 and a PTH of 30. And you're like, oh, well, the calcium dropped, the PTH should go up. No, they're both in normal range. So it's really only when we start getting outside the normal range that we start to see this inverse relationship outside normal. So a calcium of 10.0, then I should, and above, then I should start to see the PTH drop. But within that normal range, it's fine to see, to not see that inverse relationship. But again, I would want to see real numbers. I can't say it without real numbers. Okay. So he says two parts. For a 67-year-old woman with dozens of symptoms, also 5 major bone breaks in 5 years, high urine calcium, the nuclear medicine CT, so I'm guessing you had a SPECT CT, reports a high probability of parathyroid adenoma. Does this influence the diagnosis? Again, imaging does not influence the diagnosis in 99% of cases. There are rare outliers where I will use imaging to help with the diagnosis, but it is extremely rare. In almost all cases, the CT scan, especially if it's a CT scan, they are famous for giving you false positives. They will recognize things that are definitely not there. So no, I don't. It doesn't change things. The high urine calcium can change things, but high urine calcium is not diagnostic for primary hyperparathyroidism. You actually see it in secondary as well. So it's tricky. The urine calcium is definitely something I look at, but it often doesn't. It doesn't come down to a final, criteria, right? It's something that can help, but may not. Okay. Now let's see. I wanted to look back. Okay, let me bring up the comments that were posted prior to the start of this, because they don't automatically insert. So, all right. So JJ says, I live in Australia, so they do a different reference range. So yeah, if you saw a new patient that had previous serious kidney stones, again, so, and a broken wrist. Okay, so again, I'm thinking maybe this is primary hyperparathyroidism. Absolutely reasonable to think that, but have to use labs for the diagnosis. Okay, diagnosed with hyperparathyroidism at 50, I guess age 51. Calcium was at 2.56. Okay, so anything above 2.50, which is 10.0 on our scale, is high for a 51-year-old. Okay, so would you send them for a scan on their parathyroid or wait for their calcium levels to rise more? I wouldn't do either. One, I would check a PTH level with the calcium level to see if that was the cause and see if I get a correct relationship there. Bone density, it showed osteoporosis in the spine and hip, osteopenia everywhere else. I mean, we need a PTH level. If that PTH level was 51. I'm not sure if 51 was the age of the PTH. But if your calcium level was above 2.50 and that PTH level was in normal or high range, then that's diagnostic for primary hyperparathyroidism. And then you need to get it treated, especially if you already have kidney stones and fractures and osteoporosis. So I wouldn't do either. You don't need imaging again for the diagnosis, but you do need a PTH level. Okay. And next question, Susan asks, is having a slow saline flush every 1 to 2 months to keep calcium in normal range rather than medication a good idea? She also says she's diagnosed with primary hyperparathyroidism. Calcium level's been going up for about 9 months, and since July they started a new reagent to adjust for high dose biotin. Okay, so biotin's interesting because it can influence PTH levels in some labs. So sometimes you do want to stop biotin about 5 to 7 days before getting labs done, just to make sure that that's not an issue. But some labs use a different set of reagents. I don't know the details of it, but I know that some labs it doesn't influence your PTH result if you're taking biotin. It's just some labs. But since we may not know the details of your lab, just go ahead and stop it. But okay, since then my calcium numbers go down rather than up. I doubt my primary hyperparathyroidism would have been diagnosed if this change were made a year ago. That scares me. It's hard for me to get so there's a couple issues. I'm not, without specific numbers, it's hard to say exactly what's going on, Susan, but if you've already been diagnosed with primary hyperparathyroidism, that tells me you probably have high calcium levels, have inappropriate PTH levels. A slow saline flush is not really a treatment for this. I mean, yes, if you get saline, or if you drink a lot of water, you can reduce your calcium level. So if you really, just go for it and, chug a lot of water, you can reduce your calcium level. But it's not really a treatment. It's not really a cure. You really actually want to get it treated. Okay. So, Pam asks, Pam is post-op from primary hyperparathyroidism surgery, so already had parathyroid surgery, and Pam says that her calcium is now 8.1, which is low. That is low for any age. That's a low calcium level. The PTH is 189, and the vitamin D is 23. So PTH is very high here, and the vitamin D level is low. This is completely appropriate. This is actually secondary hyperparathyroidism. We'll get to that next time. But this is actually not uncommon after parathyroid surgery. The reason is that if you are not taking an appropriate amount of calcium, after parathyroid surgery, you're not getting enough vitamin D or whatever, your body needs that calcium. And so your calcium levels in your blood may drop, and your remaining parathyroid glands are appropriately making a lot of hormone because they're trying to get the calcium level up. There may be some other issue. Maybe that you're not absorbing the calcium for some reason. If you have diarrhea, you may be losing it there. You may be losing it in the urine. There's a lot of things you want to look at when evaluating secondary hyperparathyroidism, but that's what it looks like you have. It doesn't look like primary hyperparathyroidism, and it's going to be treated with vitamin D and calcium. You don't need the 50,000 units of vitamin D3 twice a week. That's a lot. Usually they do D2 when it's 50,000 twice a week, but really, you need calcium. If they haven't prescribed calcium for you, then that's going to be important. And then you also want to figure out what the underlying issue is. So is it that you're not absorbing it? Is it that you're peeing it out? Is it there, some other issue going on? I'd want to figure that out before just telling you to take a massive dose of vitamin D. You do need the vitamin D and you do need the calcium, but you need somebody to look into that a little more too. Okay, Jim asks, post-operative, is total calcium or ionized calcium more important when testing for and managing hypocalcemia? Okay, so total calcium versus ionized calcium is a good question. Total calcium for somebody who is walking around, somebody who's not in the hospital, total calcium is more reliable. Ionized calcium is a little bit more finicky as a lab and has to be handled a little bit differently. It has to be adjusted for pH. And so you may not get a reliable result. Total calcium tends to be very reliable for most people, especially if your albumin levels are normal. And that is most people walking around. They have normal albumin levels. If you are in the hospital, in the ICU, if you've been in the hospital a while or you're very sick and you have a lot of chronic medical conditions, then maybe your albumin level will be low, and that will give you a falsely low total calcium. And sometimes in those cases, ionized is more important. But really, total calcium, for the most part, is what I go by, especially in outpatients. In the hospital, you can get ionized calcium. Usually total calcium is pretty reliable. Okay. JL Law says, at what point, if any, is normocalcemic I think hyperparathyroidism considered to have evolved to primary? What is the diagnosis? So here's the thing. So the normocalcemic hyperparathyroidism, most people are talking about normocalcemic primary hyperparathyroidism. That's what they're referring to. And it is just a different version or presentation of primary hyperparathyroidism. It's still primary hyperparathyroidism. Now, the difference that I see, that I use, is if the calcium level is always normal. And typically I'm talking about the high-end normal. So if your calcium level is always on the high nines and you have very high PTH levels, that can be normocalcemic primary hyperparathyroidism. If your calcium level is ever high, if it's ever over 10.0 or 2.50, that's not normocalcemic because your calcium is not normal. It's not normal. So when does it evolve to primary? I mean, it can. Sometimes people do see that, but more often with primary hyperparathyroidism, the calcium level starts to go high, goes into the low 10s, and the PTH level will be kind of on the low normal range, and then the PTH rises with time. The calcium may rise or not. So with normocalcemic, if the calcium always stays normal, you may not ever, quote, evolve to classic primary hyperparathyroidism, but it's still primary hyperparathyroidism. But I think there's still this confusion between secondary and primary, and we'll get to secondary in a little bit. But remember, with secondary hyperparathyroidism, very different underlying mechanism. Your calcium level tends to be on the lower ends of normal, and your PTH is high as a result of that. It's not treated the same way. Okay, I'm going to go back to now the questions posted from today. Okay, so I have okay. Sorry, it's kind of jerking around. Okay. M asks, along with many of the regular symptoms, plus high calcium and high PTH, I have bilateral paresthesias, like pins and needles in both legs. Can this be a symptom as well? That is tricky. So classically, pins and needles is associated with low calcium levels. That's kind of what we tell people after surgery to look out for. But some people do get weird neurologic symptoms from high calcium, things like pins and needles, and they are related to the high calcium levels rather than the low calcium levels. So my answer to you would be maybe, especially if this has all started within the time that your calcium's been high. So if you have had this going on for 6 years, but you've had high calcium levels for the last 10 years, then there's a chance that this is the cause. If the paresthesia has preceded the high calcium for years, then it's less likely that it's related. But the high calcium could certainly make it worse because it does make neurological conditions worse because the brain and the nervous system depend on calcium. So we can see these things get worse, but it's really hard to say, and it would be hard to tell you whether or not it was truly directly caused by your high calcium. Okay. Mike asks, since the normal lab for vitamin D is the inactive form and the high PTH converts inactive to active, is it possible to get a high concerning level of active vitamin D and you'd never know it because it's not typically tested for? So it often does get high with primary hyperparathyroidism, and the main risk for high active vitamin D is high calcium, because that's what it does. So actually, this mechanism that PTH converts the inactive form to the active form, that's one way in which it causes high calcium. Another way is taking calcium out of the bones, but increasing that level of activated calcium, of activated vitamin D, actually is part of what it does. So is it possible to get a high level and never know it? Well, no, you'd see it because you'd get a high calcium. This is partly why if you have a high calcium, I tell you to not take vitamin D supplements, because it's going to get converted to the active form. And if you already have too much active form and you already have a high calcium, you can just potentially push your calcium level up even higher. So you want to get the parathyroid disease treated. Okay. Lisa says, why aren't these doctors more trained? I just don't get it. It's tough. I didn't learn any of this in medical school, and I went to Cornell. It was a good medical school. I didn't learn any of this. Parathyroid disease is not taken seriously, and for a couple of reasons. One is it's not cancer, so it's a benign tumor, so it doesn't get the attention that cancers get, and I think it's because a lot of the symptoms are nonspecific, because it is things like fatigue, brain fog, that could be due to anything. And finally, and this is kind of a sad note on our healthcare system, but it's true, this disease is much more common in older women. So tends to be postmenopausal women. And it's true that postmenopausal women tend to get dismissed by doctors, especially if they come in with non-specific symptoms. So if you come in and say, I'm tired, I can't sleep at night, they're going to blame it on menopause typically. And it's very, very common. Patients of mine come to me and they are in menopause. So maybe the symptoms are due to menopause, who knows? But they've been feeling really bad for years. So doctor's been telling them it's just menopause. But after parathyroid surgery, all of those menopause symptoms get better. So, it wasn't really menopause, or rather it could have been menopause, but the symptoms were clearly parathyroid as well. And that's the reason. So I think there's a combination of reasons why doctors aren't more trained, more educated on this. If you're not dealing with it every day, then you don't have an incentive to learn. But doctors can learn, and I think it's really important to note that doctors do learn. It's kind of slow. There's a lot of inertia, and oftentimes the most effective thing is if they have a patient come back who has had a good experience. So I will treat patients sometimes, and their doctors are not on board at all with them getting treated. They think I don't know, a fraud or something, but they tell the patient, you're not going to have any changes. You don't need surgery. Your calcium's not high enough. And then they get the surgery and they notice improvements, and they typically start to notice improvements in the first few weeks. And then they go back to their doctors and let their doctors know. And, a doctor could still refuse to see it at that point, but they're more likely at that point to then reconsider and think, oh, maybe that was actually an issue. And then they start to see it in their other patients, and that's when they start to send their other patients for treatment. The other thing is if they get parathyroid disease themselves, or their spouse gets parathyroid disease, then they suddenly find it in everybody and start sending them for treatment. Okay. Okay, Allison says, great presentation, thank you. I'm 2 years post-surgery, 2 adenomas removed. Recent labs, the calcium is 9.9, the PTH is 22, and vitamin D is 57. Concerned with vitamin D as it's increased from 35 pre-op to 57 2 years later. Okay, so your other labs look great. Your calcium level of 9.9 is perfect. PTH of 22 is perfect. That's a happy parathyroid gland, or glands. The vitamin D of 57, now it's probably because you're taking vitamin D that it's in that range, but it's not, at this point, it's not in a dangerous range. Usually I don't see issues with vitamin D until we start getting, above 50, but often more above 60. And if your calcium level were starting to head into the 10s, then I would say, okay, you want to get that vitamin D level down a little bit. At this point, because it's in the 50s and your calcium level's okay, it's probably okay, but you don't need to go that much higher. Now, it is normal for it to go from 35 and then go higher post-op. That's expected, again, because that level was suppressed before your operation. So now that you've had the operation, I expect your vitamin D level to come up. So it's come up appropriately. But you probably don't need to be taking a ton of vitamin D if it's there. But usually, 1,000 or 2,000 units a day is adequate. So if you're taking a lot more than that, I would say, drop down. But a vitamin D of 57 with a normal calcium, I'm not concerned about. That looks pretty good. Okay. Linda says, I'm 58, calcium level is 10.1 and PTH 36. Many symptoms, but my PCP says it's normal. What do you think? Okay, so a calcium level of 10.1, not normal for your age. That is elevated. Now, if it was a once off and you had a 10.1 and then every other lab was normal, okay, lab errors happen. It's not unheard of. So if it's one lab, everything else has been perfect, okay, maybe I won't act on that. I usually don't act on a single lab. But if you've had multiple levels of 10.1, that's concerning. Now, the PTH of 36 is interesting because it's in the normal range. It's not suppressed. So with a high calcium level, I expect the PTH level to be suppressed if all your glands are normal. But there is one scenario in which I don't see this. I see the PTH in the low normal range like yours, and that is if you're on high-dose vitamin D supplementation. So my first question to you would be, how much vitamin D are you taking? Because if you are taking a high dose, like 5,000 units a day, and your vitamin D level is above 50 or 60, then that could be the cause of that calcium level. Now, if you said your labs were repeated and your calcium level is 10.1 and your PTH was 60, well, that's inappropriate. Even though that PTH is a normal range, that's completely inappropriate, and that would not be the vitamin D. And so that would be diagnostic for primary hyperparathyroidism. But right now, your levels are a little bit borderline. I would want to repeat them probably a couple of times and see your vitamin D level and find out how much vitamin D you're taking before I would make a diagnosis. But I would not say those things are normal, and you shouldn't ignore it. You do want to look into that more, especially if you're having the symptoms. That the symptoms, interestingly, the symptoms of high calcium can be caused by high calcium regardless of the cause. So even if your high calcium level was caused by vitamin D, you would get the same symptoms. Okay. And JJ said the PTH was high. Yeah, so that's going back to that's primary hyperparathyroidism. Okay. Sorry, the comments tend to jump around, so it's hard to scroll. Okay. Okay, Lisa asks, if I'm going to self-refer to your clinic and my PA has ordered an ultrasound, should I hold off and have your clinic do it? My PA says she is knowledgeable about hyperparathyroidism, but her answers to my questions made me question that. She also says if I go out of state for surgery, she will not manage my care after surgery. She'll send me to the ER for any complications or questions. I'll be looking for a new PCP, but looking to get surgery as soon as possible. I have held off on her prescription for the ultrasound. Also, she did the swallow palpation test and felt a nodule. Could this be the parathyroid she felt? Okay, what do you do if you find a nodule? Okay, lots of good questions here. So Lisa has been diagnosed. The PA says she knows about this disease, but maybe doesn't know a ton. And the first question is, should you get an ultrasound? Okay, so if she felt your neck, what I'm guessing is she kind of felt along the bottom of your neck and you swallowed and she felt a little nodule there. That's not the parathyroid, typically. It's very, very rare to feel parathyroid tumors. It is very common, though, to feel thyroid nodules. So what she is likely feeling is probably a thyroid nodule. And ultrasounds are good at evaluating thyroid nodules. They are not great for finding parathyroids. So I would not tell you to get that to look for the parathyroid, but getting the ultrasound to evaluate that thyroid nodule is actually a good idea. If there is something concerning on your thyroid, if you do have a thyroid nodule, most thyroid nodules are benign, just starting off. But we have a way of classifying how they look on ultrasound to get a sense of how risky they are, meaning how likely there is a cancer in there. Because when we're looking at thyroid nodules, we're worried about cancer. Different from parathyroids, right? I'm not really worried about cancer, but for thyroid nodules, they can often grow little cancers in there, don't cause any symptoms. You just kind of incidentally find them. And so if she feels a nodule, kind of makes sense to get the ultrasound. That way we know what we're dealing with. So I would do it. I would do the ultrasound. That way we have more information before you travel. And we know, okay, is there a nodule that I'm going to have to deal with, or that needs to be biopsied beforehand because we may need to deal with it? Again, most nodules are benign. Yours probably is too, because that's how they are. But it won't hurt to get an ultrasound. The only way at which it might hurt you is if your primary care doctor then says, oh, well, it was negative, it didn't show a parathyroid tumor, so you don't have this and you don't need surgery. That's where imaging can really hurt people. So sometimes I'll discourage people from getting scans just because of that, because I don't want them to be told that they can't have surgery because something was negative. Okay. Another issue is what's going to happen after surgery when I leave. So more than half of my patients are coming out of the state of Arizona to have surgery with me. And a big question is what's going to happen when I leave. So I'm very proactive on this. I really want you to call me. I want you to call me personally. So every patient gets my cell phone number, and you can text or call me at any time. I won't necessarily wake up if you text me because it's one little beep. So just call me if you have an emergency in the middle of the night. I'll wake up for the phone. But that's what we do. Typically, most issues that occur after surgery can be dealt with over the phone. So if you call me, I'm going to be able to figure out what's going on and tell you what to do. Most of those issues are actually just related to calcium, and I can tell you how much calcium to take. So it's not very nice of her to say that she won't care for you if you go out of state for surgery. However, I have heard this before because sometimes doctors are a little bit territorial, and so if somebody is encroaching on their territory, they feel threatened, and then they refuse to help you if you go somewhere else. I'm not that concerned about that because you'll have my cell phone number. You just call me or text me if there's anything. And if you did need to go to the emergency room, I would tell you and I would talk with the ER. But that's pretty uncommon. That'd be pretty rare. I do have people stay in town the night of surgery in case there are any issues that night, because if there's going to be something that brings you back to the hospital, typically it occurs that day. And then you're able to go home the next day, like fly out of state the next day. Okay. Oh, yes. And then dealing with nodules is the final issue. So we'll get into this later when we talk about surgery, but you do want to assess the thyroid. I mean, I assess the thyroid in every patient because I'm going in there, I'm looking at all 4 parathyroid glands, right? And in doing so, I have to assess the thyroid. I mean, it's in the way. So I'm looking at the thyroid, feeling it. If there's anything suspicious, like a nodule, I can biopsy it while I'm there. If there's a big nodule, it feels benign, but it's something that you'll be following forever, I'm going to take it out usually just so that we get a final diagnosis, and we can say, okay, yep, it was benign. Now you don't need to follow it for the rest of your life and get it ultrasounded and biopsied. So I will often do that. If there is a cancer, if you realize there's a cancer when you go in there, sometimes you go in and it's a surprise, you can treat the cancer. Typically, what we do is if we discover a cancer and it's obvious, I'll have the pathologist look at it, confirm it, and then you can possibly take out that lobe of the thyroid. Again, this is pretty uncommon because most nodules are benign. So for most nodules, kind of take them out, get an assessment, they are usually benign. Okay. Oh yeah, so Kate says, I just had more labs. Calcium was 10.0. Since the calcium went down, does it indicate it might not be primary hyperparathyroidism? Well, no. With primary hyperparathyroidism, there's some nuance to the diagnosis, but the calcium level frequently fluctuates, meaning it goes from being in the normal range to being in the high range and then back to normal. And that's not uncommon, especially for the first few years of the disease. You can see it go from normal to high over time. After a few years, typically it starts to stay in the high range, but that can be very confusing for doctors because they get your labs, it comes back as a high calcium, and then so they repeat it to make sure, and now everything's normal. And then the same thing happens the next year. So this can go on for a while. What I'll do in that situation is actually get a couple of labs over a couple of weeks, check the calcium and PTH over that time, and we can often see everything fluctuating and get the diagnosis. So no, it doesn't really tell me anything, but I would just want to check more labs. Okay, I'll keep answering until I get tired. So Jessica says, I'm 44 and I have a high calcium, 10.5 to 11 since 2020. Okay, it's definitely high. I've had symptoms, fatigue, palpitations, bone pain, anxiety. PTH is 27, vitamin D is 44. I've done the imaging, ultrasound, with and with contrast, and it didn't show anything. Do you need a high PTH to get a diagnosis? Okay, this is interesting. So you don't need a high PTH to get diagnosed. Remember I said, it has to be inappropriate. So your calcium levels in the high 10s, definitely high. And if your calcium levels were normal prior to 2020, then it's even more likely that this is primary hyperparathyroidism. If your highest PTH was 27, it's unusual. It is unusual to have primary hyperparathyroidism and have PTH levels in the 20s. Not impossible. I have had people with primary hyperparathyroidism with PTH levels in the teens, which is sort of suppressed, but they've had primary hyperparathyroidism. So it is possible. In your situation, though, because it's unusual, I would want to dig deeper, and I'd want more PTH levels. So as I mentioned before, there's certain things that can influence the PTH. So if you're taking high-dose biotin and you haven't stopped for the test, you may be going to a lab that where the biotin is influencing the PTH level, and you need to stop that and recheck it. If your PTH level has only been drawn at the doctor's office and getting mailed out, that could be a problem because PTH is a little bit finicky. So I recommend getting it done at LabCorp or Quest, one of the labs where they're doing it there and that's all they do, because then they're more likely to handle the specimen appropriately and get an accurate result. So you may still have it. It's not required, but I would want to dig a little bit deeper before making a final diagnosis. Okay. Okay. Yeah, and okay. Rachel asks, is it normal for the common symptoms like fatigue, malaise, insomnia, again, the big ones, is it normal for those to not resolve after a successful surgery for primary hyperparathyroidism? Okay. So you said you've likely had it for over 20 years, may have started as a teenager, one gland adenoma was removed. I see genetics next week, but there isn't anyone with this disease or evidence of it in my family, no one with osteoporosis or kidney stones. Okay, so couple things. So so I'm assuming you have primary hyperparathyroidism, and you had one gland removed. Are you cured? And why are you seeing genetics? Because it's a little bit weird to just see genetics if there's one for a single adenoma with primary hyperparathyroidism. So I'm not sure. You may have something going on, but I feel like I'm not getting the full story, because one, it's unusual for primary hyperparathyroidism to start as a teenager. It does. I've operated on 12-year-olds with this, but it's not the most common scenario. When it does start that young, usually it is a single adenoma. I'm assuming you're seeing genetics because you're not cured and they think you have more tumors. So in that case, it would be normal for the symptoms to not resolve. But I'll go off for a second. The issue is that I get a lot from a lot of people is, are my symptoms going to resolve? And I can't answer that for you because it's just not possible. Everybody's a little bit different. on average, people feel better. On average, the symptoms like fatigue, brain fog, insomnia, they get better. They get better in the weeks after surgery, but they won't for everyone. And I know that sucks. I know you want all of these symptoms to resolve, and I wish they did too. There are certain things that can tell me that it's more likely to get better, or that you're more likely to feel relief from these symptoms. That would be if your symptoms only started since you had high calcium. So if your calcium was started to become high 5 years ago, and 2 years ago you started getting really tired and getting brain fog and having depression, very likely that those symptoms were caused by your parathyroid disease, and they're going to get better after surgery. But if you've had issues, like if you've had fatigue and bone pain, joint pain for the last 30 years, but your calcium has only been high the last 5 years, it's much less likely that you're going to feel relief from these. Now, you may feel better because parathyroid disease could be contributing more to it, but I'm not going to tell you that all of these things are going to resolve, because there's a higher chance that you've got multiple issues contributing to your symptoms. So the longer that's been going on, the higher the chances that there's something else contributing to the symptoms. Okay. Okay, so Denise says, why does everyone say the symptoms are caused by high calcium when normocalcemic hyperparathyroidism causes a lot of severe symptoms as well? So really good question. Again, normocalcemic is a very popular topic. It is less common than it gets diagnosed. So it's diagnosed more often than it really exists, because a lot of people will say something is normocalcemic, but then I look at their calcium levels and I'm like, they're not normal. These calcium levels are high. But you're right, normocalcemic primary hyperparathyroidism can cause symptoms. Now, how it causes symptoms is less clear to us, because we know calcium is involved in all of this. So remember I told you calcium, it's involved in nerve signaling, in brain function, in blood clotting, in arterial stiffness. I mean, it's directly involved in all of these things. PTH is as well, sort of, but we don't understand it as well. We know the role of calcium in all of this, and it makes sense that a high calcium level would affect your nerve functioning, because we know it has a direct effect on nerves. We know that it's involved. With PTH, how is it actually affecting it? Less clear. We do know that there are PTH receptors throughout the body. The highest concentration of them is in the bones and the kidneys, which makes sense. That's the main thing that it does. But we know that other organs have PTH receptors. And so could that be part of why you get symptoms? Yes. Particularly bone pain. Bone pain is definitely one where we can understand why the high PTH causes symptoms, because it's actively taking calcium out of the bones. But how a high PTH would cause, say, fatigue, it's harder to explain. So I think that's why we kind of focus on explaining them with the high calcium, because it is harder to explain exactly how a PTH itself would do some of that. Okay. Terry says, I get my results tomorrow after 15 days from surgery. 3.5 adenomas. Should I be nervous for results, or would they have called if there was an issue before today? I'm not sure what results you're looking for. Also, 3.5 adenomas, that sounds like hyperplasia. So because having like that many adenomas would be pretty unlikely. If you've got all 4 glands involved, that is hyperplasia. You have to kind of make that assumption that it's hyperplasia, which is a little bit different pathology, same disease. You treat it by taking out 3.5 glands. I'm not sure what you're getting done, so I guess you're getting labs checked at 15 days. I usually don't check labs at 15 days, because things can still be a little bit wacky at that point. Would they have called if there was an issue? I'm not sure what issue you're referring to, because by this point, if you were having issues with say, low calcium, you would actually be feeling it. If you're worried that they might find cancer, they didn't call you because they're not even, it's not cancerous. These are benign tumors, and yes, they would have called you if there was cancer. But it's so rare there isn't. So I'm not sure, but good luck getting the results. Hopefully you're doing well. Oh, Denise says, I have a variant of unknown significance in the CASR gene. Okay, that makes sense. So, variant of, we'll get into this. There's a very good chance that you have FHH, or familial hypocalciuric hypercalcemia, if you have high calcium levels and this variant of unknown significance. You had surgery. It sounds like the calcium is still high because of that gene mutation. A lot of these variant of unknown significance, eventually we do know the significance, but when they're first found, we don't know the significance. We just know that it's a variant that is not found in most people. So it sounds like you have FHH. Okay, Giovanna asks, do wild fluctuations in thyroid labs and high doses of levothyroxine cause issues with the parathyroid? I only had parathyroid checked before Prolia injection for osteoporosis. Labs were 990. No, your thyroid and your parathyroid are two separate glands. So fluctuations in your thyroid labs and levothyroxine should not cause parathyroid issues. Now, occasionally, like very active, like hyperthyroidism can cause high calcium levels. That's uncommon, but can do it. Now, Prolia, or these injections, a lot of these treatments for osteoporosis can drop your calcium level temporarily after the injection, and your PTH level can rise. But a PTH of 990 is extremely high. I'm not sure if that is correct. That's typically a level we would see in patients like on dialysis. So it's kind of weird. I'm not sure if that's accurate. That my first thought is that accurate? I would want to just repeat everything with a calcium level before making any assumption, because it's unusual to just see a 990 just randomly. Okay. Okay, and Jessica says, thank you for answering my question. I'm in the gray. You are in the gray area. Doesn't mean you should ignore it, though. I would keep an eye on it, because having those high calcium levels is not good for you. Okay, and thank you. And Susan, okay, one more. This is my last question. Susan asks, my PTH has been elevated since 2020. Multiple symptoms: hypertension, diabetes, CKD, GERD, bone loss. Calcium is generally in the 9s, but urine calcium is 17. Vitamin D. Is the 17, is that in milligrams over 24 hours? Because that is very low. PTH is 72 to 179. Calcium challenge for 2 weeks. Repeat labs, PTH is 124. Calcium 8.4. Vitamin D 50. Urine calcium so low it wasn't calculated. Where's all my calcium going? They're calling the secondary, but taking all the calcium, I didn't expect my PTH to go up. Okay. All right. Yeah. So that is that's a 24-hour. Okay. So interesting scenario. Calcium level, if your calcium level has generally been in the low 9s, then that would suggest secondary, and that fits with the calcium of 8.4. Now, where is the calcium going? It depends on how much calcium you were taking. So yeah, typically if you were taking 2,400 milligrams of elemental calcium, I would expect your calcium level hopefully to rise, or to at least see the PTH drop down. A lot of times when I start calcium supplementation for secondary, I actually don't see the calcium level rise very quickly, but the PTH level will come down. But I usually don't repeat them after 2 weeks. So if I've diagnosed secondary hyperparathyroidism, which that's what it looks like you have, right? It looks like not much calcium is going into your urine. Again, that's appropriate. Your body's doing the right thing. That's partly the PTH, right? Holding on to the calcium. And you do need to take calcium. The issue is figuring out what the cause is. So why aren't you absorbing the calcium? Do you have something like chronic diarrhea? Have you had a gastric bypass? Because that would do it. Or any other surgery where they removed part of your duodenum or a lot of the small intestine. Or do you have chronic diarrhea from any cause, like IBS? These are the common things I see causing these kind of absorption issues, where you get this secondary hyperparathyroidism and with very low urine calcium because your body's trying to hold on to it. So that's what it looks like. I would want to check your calcium, make sure you're actually taking the 2,400 milligrams a day, and make sure that that's really what you're getting. But it may just mean that you need to take this over a longer period of time, and we're not going to see the effect in 2 weeks. Because I usually give it a couple of months. And a lot of times, like I said, PTH, the calcium may not have come up yet, but the PTH will start to come down. So, and then I just continue the calcium and vitamin D supplementation. You're taking calcium citrate. Okay, so and you've read the bottle appropriately. I just did a video on this about the bottle they're often very hard to read. It's how many milligrams are in each pill. You have to check that and make sure you're getting it. Make sure you're spreading the calcium throughout the day so you're not taking it all at once. I also counsel people on avoiding spinach because that's really high in oxalates and that will bind to the calcium, so you're not going to get all of it. And if you want to look at kind of a low oxalate diet, that's a good idea. And just look into, Val, you said there's no absorption issue. You haven't had surgery. That's good. But it looks like, you're not, and you're not. Okay. So you know how to read it. 600 4 times a day. Yeah. I mean, it looks like you probably just need more. I mean, or need it for a longer period of time. You just haven't given it enough time. And I know that the issue is, you would expect these to kind of drop. You might not see a lot of changes. These labs, especially when the calcium's kind of high, when the calcium's low, the PTH is high like this, you're going to see these wild fluctuations. So you might check it tomorrow and it might be down. But basically, I would keep it up and follow it over a longer period of time, not just 2 weeks. Mariah says, what dose of calcium for a couple months? And I was told to take Tums Ultra once a day. So Tums is interesting. Tums is tricky. Tums is an antacid, so the dosing is given as calcium carbonate, not as elemental calcium. So when you're taking Tums, if you're taking the one that has 1,000 milligrams of Tums, it actually only contains 400 milligrams of calcium. So if you do have secondary, 400 milligrams of calcium is probably not enough. Now, you can take Tums calcium carbonate. It does work. It's fine. A lot of people can't tolerate it because of constipation, but if you can tolerate it, go ahead and take it. But you likely need more. And you need to just follow it. Pay closer attention to how much is in each one. Okay. And Susan, I'm not surprised you have bone pain with that high PTH level. I would keep trying the calcium. What I would do too is, take different forms. So I know calcium citrate is one we all love. It's, it's the one that, has better absorption, whatever. But what I'll do is I'll kind of, try other forms and alternate them. So, calcium carbonate and calcium citrate, even taking Tums. Another way is if you're taking like hard pills, to get something that's chewable or gummy, because then you have the best shot of absorbing it throughout your intestinal tract, right? Rather than waiting for it to break down. So I'll have people switch to chewables, alternate calcium citrate and carbonate. There's even calcium citrate powder, which you can put in your drink. It's a little bit chalky, but put it in there, mix it up, and then you can drink it throughout the day. That way you're getting that small amount. I would look into the low oxalate diet. And you're likely going to need to stay on calcium long term, because whatever the issue is with absorption, it's not going to go away in 3 months typically, unless there was some acute issue and you were able to fix it. It may mean that you need to be on calcium long term. But it sounds like there may be something else going on, but it's not clear. Okay. So I said I was only going to do one more, but a sibling also had primary hyperparathyroidism, had surgery a little over a year ago, can't get his calcium up, taking 2,000 milligrams of calcium a day, plus dietary calcium, no bariatric surgery, no calcium in urine, constipation's bad for years. So it depends on what the PTH level is. If your PTH is elevated, that means you're other parathyroid glands are working appropriately. pTH not elevated, that's a separate problem. If the pTH is low, for example, after surgery, that means that the remaining parathyroid glands are not making enough pTH. But okay, I need to get to the gym, so I'm gonna head out now. Thank you everybody for logging on and participating. Again, there's more videos now on YouTube, so go over there and subscribe. And I will be back next month, and we'll cover more topics. Okay, all right. Have a good evening.